This is Dr. Erdi Fadrigilan. I am a cardiac electrophysiologist, and my subspecialty deals with abnormal heartbeat. We will have the second part of the video series on basic ECG. And if you haven't seen the first part, the link is in the description box below. If you like similar contents, please consider subscribing to my channel, share and like the video, and hit the notification bell so you will not miss any updates. So without further ado, let's jump to the video.
We need to appreciate how the waveforms are generated and how they are sensed by that of the sensing electrode of the individual electrode of that of the ECG. So this is the rule of the current flow and its detection. If the current is going directly towards a recording electrode, it will record a large positive deflection, and the opposite of the current flow, if it's going away, will be similarly large, but on the negative or opposite direction. If current flow will be perpendicular, like for example, going up like this one and going down like this one, and this is the perpendicular electrode. For example, let's take this waveform. If the current flow will be going towards that of the recording electrode, it will initially record a positive deflection, but it's going to be small since it's perpendicular. Once the impulse is directly under that of the electrode, it will go into that of the isoelectric baseline, and as it goes away, record a negative terminal. And again, it's a smaller amplitude compared to that of a wave going directly towards an electrode or going directly away from that electrode. And any combination or any direction would actually produce, like for example, for this one, since this is not directly going towards that electrode, although in general direction is towards that electrode, it is not as direct as this one. It will record a positive deflection, but the amplitude is not going to be that large. Now, the heart is in the center of the chest, and the leads are actually designed to be placed surrounding that. Now, the limb leads would be comprised of the one on the right, then on the left, and one on the foot, and then one neutral ground or a neutral lead. That will represent and will create 6 limb leads, which we will go through later. And there are likewise in the standard ECG 6 precordial leads, or the ones placed in the chest. Now, we need to review where they are placed. Of course, V1 will be in the 4th intercostal space, so V2, but V1 is on the right of the sternum. V2 would be on the left parasternal area. V4 will be on the 5th intercostal space, V5 and V6 as well, but V4 would be in the mid-clavicular line, V5 would be the anterior axillary line, and V6 would be on the mid-axillary line. So you need to appreciate that V6 should be placed well lateral into the mid-axillary line. Now, V3 will be somewhere around between V2 and that of V4. Now, the 3 limb leads would actually create 6 limb leads, with primary that of lead 1, lead 2, and lead 3, and the combinations of polarity would now create the augmented limb leads, which we term as the AVR on the right, AVL on the left, and AVF, of course, on the foot side. Now, they are able to record vectors from that of the negative towards positive, because that's how basically the generation of the direction of electricity is. So if you have an electrode going to lead 1, then lead 1 would actually be recording a positive impulse. And that would be the same with that of the precordial leads. We have again V1 to that of the V6. So again, the generation will be that of a negative towards positive. So if in the normal ECG, you will see that V5 and V6 are strongly positive, meaning that the direction of the vectors or the impulse will be going towards V5 and V6. So if you look and try to imagine that this would be the heart at the center of the chest. So V1 and V2 would actually be looking at different directions, such similar to that of V5 and V6, as well as that of the limb leads, such that in patients, we know that AVL and V1 would actually be looking at the lateral aspect of the left ventricle. Leads 2, 3, and AVF will be looking at the inferior part of the heart. With the precordial leads, if you imagine the LV to be in the center of this figure, you will appreciate that V1 and V2 will be looking at the septum of the left ventricle. V3 and V4 will be looking at the anterior part of the ventricle, and the lateral part of the ventricle will be closest to that of V5 and V6. That's why we term V1 and V2 to be septal leads, V3 and V4 to be anterior leads, and the lateral leads will be V5 and V6. Now, it is important that we realize the impact of lead placement in patients, that we need to make sure that the leads are correctly placed, because that's how the normal ECG in a patient will be recorded in a normal manner. If there will be interchange of the leads, the most common is that of the right and the left arm interchange between that of the R and that of the L leads. The changes that we will see actually will be that of lead 1 would be completely inverted because the left and the right leads will be interchanged. Lead AVR will now be completely positive. And you know that this is wrong because we know that the conduction system, that there is sidedness. It would be going to be right to left, and this one, it's going to be left to right because, again, lead 1 is left-sided, AVR is right-sided. So in normal individuals, in normal recording, lead 1 should be upright and AVR should be completely negative in all its complexes. So that configuration would actually change the axis to mark right axis deviation, with lead 1 being negative and lead 2 and lead AVF and lead 3 becoming positive. And this is how the correct lead placement and how the wrong lead placement would actually be recorded in the ECG. So again, it is important to make sure that the leads are placed correctly. Now, when it comes to the recording, it is also important that we appreciate and look at the standardization. The paper speed, which will be measured in time, is running at around 25 millimeters per second. That will give you this time frame when you look at the box of the grids of the paper. One big box will give you, which is composed of 5 small boxes, will give you that of a 0.2 second. Now, for each small box, it will be 0.04 second. And if you count 5 big boxes, 1, 2, 3, 4, 5, 5 times 0.2, they will represent 1 second. So in the x-axis, which is going to be that of the amplitude, it is now measured in millimeters and millivolts. So for the standard amplitude standardization, you will see this square wave, which will actually occupy 2 big squares in amplitude or vertically. And this will represent that for each 10 millimeters measurement, that it would be equivalent to 1 millivolt. So one small square will be 0.1 and 5 will be 0.5 millivolt when it comes to that of the time. So you need to be cognizant of that, because if the paper would actually be run twice, like for example, 50 millimeters per second, and some ECGs can actually run it at 100 millimeters per second, you can just imagine all the intervals and the durations widening. Similarly, if you are not aware of that of the standardization, you will see that the amplitudes are actually changing based on the standardization. This is the standard, this is half the standard, and this is twice the standard. So you might mistake this for increased amplitude, which are used basically for that of criteria for chamber enlargement.